So it's great pleasure for me to introduce Dr. Colin Barker, who, although he sometimes looks young and some days he looks old, depending on how many difficult patients he had that day, he really is one of our true experts in using catheter techniques to fix the broken heart. So Colin is going to tell you all about that.
Great. Thank you, Q. I'll try not to take offense to that remark about the heart failure doctors being the smartest, but I probably agree with it. So I'm going to specifically talk about, as Q had discussed, how we these days fix broken hearts. And specifically, I'm going to focus mostly on how we fix blocked arteries, because that's probably the most common thing we do these days in cardiology and interventional cardiology, which is what I am specifically. And so I'm going to be talking about coronary artery disease. And when we think about coronary artery disease, we break it down into two populations or two categories of patients. There are those who have stable coronary artery disease, and this is truly a medical disease. If somebody has blocked arteries, just because it's blocked, that doesn't mean they need a stent or a bypass surgery. It generally means they need to go on some medicines, as you've heard about, and maybe some aggressive lifestyle modification, meaning get a little bit more active, watch how much you drink, quit smoking, etc. But stable coronary artery disease is just that, it's stable. If we start poking you with catheters or sending you for procedures, we've turned a stable person into an unstable person. Counter that to an unstable situation, which is a heart attack. And there are still 1 million people a year in the United States who have heart attacks, and half of them, or more than half of them, are women. So heart attacks are a much different population, and that's a population of patients where we do want to be aggressive. And one of the issues with women who are having heart attacks, a lot of times they actually get undertreated for various reasons, as we'll discuss. So this picture sort of splits these two populations down into the stable coronary artery disease on the left and the unstable coronary artery disease on the right. And the stable, as you heard about earlier this morning, get this to work, from Dr. Cooke and others, is just a gradual narrowing of the artery with calcium and inflammatory cells and cholesterol and et cetera. But it never becomes unstable, meaning there's not a rapid transition. This is a very slow narrowing over time, which can lead to symptoms. And the symptoms can be various. The most common one, and still a common one in women, is chest pain and chest discomfort, shortness of breath, fatigue, nausea. I mean, a lot of vague things also sometimes have to be teased out, whether or not this is truly a symptom from a blocked artery or is it something else. Usually it's something that can be induced or triggered fairly predictive. For example, if there's a certain activity you do and every time you climb halfway up the stairs you have the same symptom, odds are that's probably one of these sort of stable narrowings, and you'd want to see a heart doctor to get evaluated. It does not mean there's any heart damage. I mean, your heart has a lot of redundancy in the vasculature, and therefore, if there are narrowings in one segment, another segment can usually fill in and help supply the blood. Counter that to a very different scenario where somebody comes in with a sudden change in how they're feeling. They fainted, they passed out, they felt suddenly very nauseous and sweaty and short of breath, or had the typical sudden sort of chest discomfort, maybe it's radiating to their jaw or their arm. That's more indicative of a heart attack, which, unlike this gradual buildup and narrowing, is a sudden disruption, as you saw earlier, to the layering of these plaques, where a clot's formed. And that clot is there because the body senses some disruption to the normal architecture of the inside of an artery, and it thinks it has to form a clot to stop whatever the injury is, but in so forming that clot, it blocks off the entire artery. And the problem with that is this is a picture of a heart, and these are the arteries, which we'll go through in a second. But once you cut off the blood supply to an artery, it's suffocating. It's not getting the oxygen and nutrients that it needs, and there you do get death of muscle and subsequent heart failure, et cetera, which you have heard about. So coronary artery disease is specifically the term used to describe these narrowings inside the coronary arteries. There are 3 main coronary arteries around your heart. There's one on the right that actually goes to the back of your heart that supplies generally 20 to 25% of your heart muscle. And then there's the left coronary artery that has two main branches in the front and the side of your heart that generally supplies about 75 to 80% of your heart muscle. So as you saw in Dr. Kurrelmeyer's talk, these are angiograms. So this is how, when you get to the point where you need to see someone like me, where there's a concern about a blockage, or in this case, a actually relatively young woman, but who unfortunately had diabetes, came in with a heart attack. These are X-ray pictures, and these are catheters and tubes. We can either insert them from the wrist or the groin, and I'll talk about that a little bit more in a minute. And then we inject dye, and under X-ray vision, the dye appears black. So all these black lines you're seeing here are the coronary arteries. And they should all, in a healthy person, they're very laminar and uniform in their size and shape. So they should be nice, long, dark tubes. But where you see things start to suddenly get small or sort of peter away here and up here, that's coronary artery disease. So this allows us to see it. But as far as assessing the significance of these blockages, we either need something like a stress test or some tests we can do in the Cath lab that I'll show you in a minute. So for stable coronary artery disease, as I mentioned, this is medical therapy. This is a medical disease. It does not require a mechanical intervention. And we treat people with medicines for two reasons. We either want to make you feel better or we want you to live longer. So the medicines we give you to feel better when you're having angina are things like nitrates. You'll see people sometimes carry around these little black or dark brown pills containing little nitrates they put under their tongues. The beta blockers, as you heard about for heart failure, also can help decrease the work of the heart and decrease your symptoms. And then an interesting drug called ranolazine, which has some mechanism, a little bit vague, but it relaxes the heart and seems to actually work, I think, better in women than men. Things that we can give you that won't necessarily make you feel better, but will at least improve your prognosis or prolong your life, include drugs like statins, or if you're statin intolerant, there's some newer class of injectables. The medicines that we give to control people's blood pressure and diabetes, and then aspirin and other blood thinners. And the aspirin is preventive because it prevents those blood clots from forming that cause a heart attack. So, on a safe dose of aspirin, there's evidence that can prevent, taking an aspirin a day still can prevent a stroke or a heart attack. So here's an example of a woman who was completely fine and figured it was time to see a cardiologist and got a stress test that was reported to be abnormal, went for a heart cath, and was told she needed emergent heart bypass surgery. And so this gets at what I think Dr. Quin has highlighted nicely. If you ever feel uncomfortable that you're being sort of recommended for some therapy that's very invasive, even though you feel completely fine, you should get a second opinion. And that's what this woman did. So here was a picture of her angiograms from the other hospital. And this is that right coronary artery in the back of the heart. And these two pictures are the left coronary artery in the front of the heart. And the yellow arrows are pointing to the blockages. So they quantified these, and anywhere from 50 to 70%, which is considered significant. But understand, when I look at this blockage, I am assessing it just as you are. And even though I do this all day and every day, our variability, even my own variability, if you showed me this picture 10 different times on 10 different days, I may give you a different percentage each time on how much this is narrowed. So it's not a perfect science when you hear I got a 50% here, a 70% here, a 90% there. But there are blockages. So the question is, what's the significance of these blockages? Are they truly blocking blood flow? Because we can't tell on an angiogram if they're actually blocking blood flow. I can just tell you there's a narrowing there. I can't tell you anything about blocking the blood flow. So we can bring people in and do a test in the Cath lab where we actually put a little wire down here and measure pressure on either side of the blockage, and that tells us whether or not there's a significant decrease in flow warranting something like bypass surgery or a stent. And so here's what the test looks like. So you see two things here. You see a red and a green line with waves that are each time the heart beats. And what's important here to notice is that they're essentially superimposed. So that means that this is not really a significant blockage. If there was a significant blockage, this green line would drop way down here. This is pressure. So if this green line dropped way down here and the red line stayed up there, and you had a ratio of less than 0.75 or 0.8, that we know would warrant some sort of intervention, a stent or a bypass surgery, which would improve your prognosis. If it's not that bad, we know that moving forward with a stent or a bypass could actually be harmful, and it should be deferred, any sort of medical intervention. Counter that to this branch artery, where clearly you see a separation of the green and red lines, indicating a significant drop in pressure from the beginning of that blockage to downstream from that blockage. So this is someone who would benefit from a stenting procedure, and you can see here, this was the artery, you may not recall, but it had a lot of sort of lumpy, bumpy narrowings, and now has 2 stents and looks fairly laminar and normal and nice and robust. And when we repeat that test to see if there's any decrease in blood flow, it's resolved. The same thing for the artery in the back of the heart, and we actually checked it a few times. We can pull the wire back and forth to make sure we're not being fooled by some artifact, and confirm that this is truly a significant blockage with a ratio of 0.53. So again, that got fixed with 1 stent and completely resolved their drop in blood flow. So you can see in this one case, I think a bypass surgery would have probably been too aggressive and maybe even inappropriate given the need that this was only the 2 side branch arteries. And so this woman got treated clearly much less invasively and also more appropriately with a more tailored approach where we didn't just look at the angiogram, we also looked at how, physiologically, how much blood is being narrowed or being obstructed from that lesion. So here's what heart stents look like. They're made out of different metals, either platinum chromium or cobalt chromium. There's not enough metal in these to have any issues with MRIs or going through the airport security or being near microwaves, et cetera. They're tiny little things, as you can see, in relation to someone's hand. They're made on a long catheter that's over, about a yard and a half long, with a balloon at the end of it that's like a piece of string. And so when we're putting stents into arteries, we can get that piece of string up through this blockage, which is here in yellow. The balloon is inflated to expand the stent, because that's the only way to get it up here is to have it sort of crimped down or smushed on the balloon, and then get it to the position you want, and then make it larger so that it opens up the vessel and frees flow. And then you take everything out except for the stent. The stent's a permanent implant. They don't come out. There was a time when we were excited about stents that could potentially be absorbable, but it turns out they were causing more heart attacks than if you didn't have the stent at all. So for now, they're kind of back in the research realm. So these are permanent implants, and they provide a scaffolding to keep your artery propped open. And over time, you grow a layer of cells like a carpet on the inside of that stent wall, and it just becomes part of your artery. And we know these days the stents we use that also have medicines on them to prevent your body from rejecting them, there's about a 5% risk that over time this may re-narrow from scar tissue or more plaque, but a 95% chance that over time this is going to do just fine. So this has come a long way from just doing balloon angioplasties and unmedicated stents to where now we have very durable stents that have a good longevity. So now switching gears a little bit to heart attacks. And as I showed, this is a result of a blood clot forming on a part of the inside of the artery wall where there's a plaque that's been disrupted. And your body sees that as something harmful, like a cut on your hand, and wants to seal it with a clot. But given your heart arteries are generally 2.5 to 4 millimeters in diameter. So they're very, very small. So it doesn't take much of a blood clot to obstruct blood flow and subsequently cause heart muscle death. So this is the case where you don't want to meet me. It's usually at sort of an inconvenient hour. I generally have a mask on and a hat, and we're all talking very quickly and saying, "Good evening, Mrs. Smith. You're in the midst of a heart attack. Things are going to go kind of fast here." and you'll notice people are sort of hustling around because we're obligated, based on scientific literature, to try to get this artery open ASAP. The national standard is getting this artery open within 90 minutes, an hour and a half of showing up to the hospital. Our internal standard is 60 minutes. So that means if I'm at home in bed or I'm out at a kid's soccer game and I get called, me and the rest of the team have to mobilize and get here and meet you and get you on the table and get you prepped and get in there and fix that artery in 60 minutes. And for the most part, we do that fairly successfully, these days getting closer and closer to 100%. One of the things I do like to sort of highlight, particularly when it comes to women and having heart procedures, is that there are different ways of getting from a peripheral artery, like in your wrist or your leg, up to your heart. All our arteries are connected. So we can put a tube anywhere in your body and I can end up getting to the heart one way or the other. The issue is there's different levels of safety. And one of the biggest risks for having a complication from a heart cath is being a woman. Women bleed more, they have more vascular complications in every single study you look at. So generally these procedures are done from the groin artery. The elbow artery, for the most part, has fallen out of favor. But really, how most women should be treated now is approaching them through their wrist artery. And you can feel this pulse that's just below your thumb, and that's what we'll be doing, and we numb it up. You don't feel much when we put the catheter in. And one of the reasons why we try to avoid the groin now is that after one of those procedures, you have to lay in bed for several hours, requires sort of more workforce demands. You end up getting back pain, you can't get up and go to the bathroom. I mean, it's just uncomfortable. And again, there's much more in the way of complications from these arteries in your groin as far as bleeding and obstruction, et cetera. Whereas if the procedure was done from the wrist artery, you eliminate these complications. I mean, I can see that wrist artery right there, and if it's bleeding, just put my finger on it, or you can put your finger on it, if you're there in bed. Everything comes out immediately. You can get up and go to the bathroom right away if you got to go to the bathroom. You can get up and go home in an hour after one of these procedures, whereas with the other procedures, you generally stay 4 to 6 hours or even overnight sometimes. And again, from an economic standpoint, it's cheaper and people prefer it. So when we look at post-heart cath bleeding complications, this just shows from a lot of our literature that people who have bleeding episodes have higher mortality. So whatever we can do to prevent bleeding, we should do. It also adds a significant amount of cost to the healthcare system. And as I mentioned, women, when you compare women to all other populations, their bleeding rate is always higher. And it's for various reasons, but it's across the board always an issue. And if you look at people who are treated with heart caths in the throes of a heart attack, this is looking at death. And in the black are people who were treated in 2 large studies through their groin, and in the blue are people who were treated in the same 2 large studies and randomized to be treating through the wrist. You have a 50% greater chance of dying simply if the procedure is done through your groin than your wrist, and that's not even anything you can control. That just ends up who's on call that night. Do they know how to do this? If they don't, you got a little bit of an increase in your risk. So we have obviously adopted this and do a lot of education and outreach into teaching others how to do the procedure through the wrist. One other interesting thing is just asking people what they prefer. So this was 200 patients who were assigned to either a procedure through their wrist or their groin. And of those who had both, 80% said, if I have to do this again, do it through my wrist. So that's pretty compelling to say clearly there's an advantage from you as the patient, particularly as a woman, to having this done through your wrist. So to highlight that, I'm going to show you 2 actual cases of people we treated here. And this was a 49-year-old woman who really didn't have any history of heart disease and came in pretty suddenly tired with some abdominal pain. She was getting worked up for, maybe a gallbladder issue or something, but eventually got an EKG and was noted that she was having a heart attack. So this is one of those angiograms, and we're doing it from the wrist. And what you'll appreciate, just because I'm going to show you a few shots here in the same projection, but there's an artery here that's missing. It's a little faint here at the end, but it's because there's a blood clot sitting right up here. So we put our wire down. This is the balloon to just get some initial inflow and relief to the artery, and you see it's this whole thing here. So that whole thing was gone, so you can imagine this part of the heart was really suffocating and slowly dying. And then this is to fix it permanently, we put in one of these stents. So this is what the stent looks like as we're positioning it. Again, we inflate it with that balloon, take everything out, and there's the artery, there's the stent, keeping it permanently open. So as we were doing this case, this was a couple of years ago, literally simultaneously in the next room, one of my colleagues was treating an 87-year-old woman who had just had shoulder surgery a couple of weeks ago and was coming in with a full-fledged heart attack. She was put in the next room. It was early on. The team wasn't is aware of the advantage of doing these transradial through your wrist as they are now. So they did it through the groin. And she had what Dr. Park just talked about, this stress-induced cardiomyopathy, this Takotsubo's cardiomyopathy. Her heart arteries were totally fine. And she was sent to the CCU. And just to show you what this stress-induced cardiomyopathy looks like, this is the heart, and really it should all be squeezing. All this black stuff should be moving out of here, but there's only one part of the heart moving. There's about 80% of the heart that's just like a big bag. It's just not moving at all. But this should get better given that this ended up being this Takotsubo cardiomyopathy. Within a few weeks it recovers. And here they took a picture of the groin artery, and it looked fine, and this is a small catheter. And so they took it out, this tube, and both patients went to the CCU, and then I was on call that night for everyone and got called because one of the heart attack patients isn't doing well, so I was worried about the guy who had the heart attack, the young lady. But it turns out it was the woman with the Takotsubo cardiomyopathy had a cold right leg, and she had an ultrasound that showed the artery in her groin had blocked, and now she had no perfusion to her leg, and she had to go to the operating room for emergency surgery. And she stayed in the hospital for 2 weeks and then went on to rehab and sort of limped along, whereas the first woman stayed for 2 days and went home and did fine. I think a lot of it had to do with the complication that she had as a result of the heart cath. Lastly, we still do heart surgery on people. It's become more and more rare, generally in people who have diabetes and more than 1 or 2 arteries blocked and have symptoms. Do better with heart bypass surgery than stents. And we have, obviously a long tradition here of heart surgery and still have excellent surgeons who are, most of whom were students of Dr. DeBakey. And this is one of his first cases in 1964, showing a diagram and then an angiogram of what he did. There was a blockage in the main artery. He took a vein from the patient's leg to bypass it from the aorta, the main artery, down past the narrowing so that this part of the artery got normal blood flow. And they showed that on an angiogram, and just like we do today, they showed it on that test where we saw the green and red lines, where there was a significant difference in the 2 lines, but once they fixed the blockage, the flows were back to normal. So with that, I'll close and thank you for your time.